I would now like to reflect on my performances throughout the semester centered towards cardiac arrest and the unconscious cardiac patient. I'll be doing so once again using the Gibbs model. So first of all, talking about what happened. So yeah, every time it was walk into the unconscious patient, and keeping the standard approach of universal precautions, so gloves, goggles, overalls. Walking into the patient, obviously checking for any dangers, not any dangers any of the times I did it. Eliciting a response, or trying to elicit a response, but to no avail, and no response to any form of painful stimulus either, whether it's trap squeeze or nail bed pressure. So I guess at that point it was, being the first couple of times I had a go at it in prac classes, was you start thinking, this is pretty intense, and if you think, about paramedics and ambulance having no experience in it, you might think this is what they do all the time. So yeah, walk in and you automatically have to start thinking about that process of, what do I have to do? What do I have to get done within a certain time frame? What do the guidelines say? And, trying to manage that, but also trying to manage your time effectively. And it's a pretty stressful feeling the first couple of times we did it. I know it's just a practical scenario, but still, you can imagine trying to run it like a real world scenario. It's a very, very stressful situation. So first couple of times I was actually pretty happy with my ability to go about sticking to the guidelines. So as far as CPR guidelines and keeping the right ratios, the right rate, I thought that I was able to get into CPR quite quickly, and to recognise that that's what needed to happen with the basics of 100 per minute. Once we got into ventilations, it being 30 to 2. So yeah, initially I thought I managed it quite well in the first few tries, and definitely by the last few tries with getting that initial part down of recognising that he's pulseless after doing an initial quick primary survey, jumping into CPR, applying the pads, and I guess that's where the first issues was recognising rhythms. It's something that takes a lot of practice. I've found that out the hard way. It's not something you can pick up, and you can't afford to, at the same token, to rush your reading of the rhythm and to rush your primary diagnosis. But at the same time, you don't have time to stop and actively think, because this patient's unconscious on the ground and maybe in a lot of trouble. So I think finding the balance was quite tricky to start with, definitely. My first scenario, I confused VT with SVT. So yeah, that being able to feel confident in your knowledge of ECGs is something I feel is a lot stronger now. But definitely the first few times that was a big issue. After that, once the decision had been made, once the correct decision can be made as far as to defibrillate or not, so if they're in pulseless VT or VF, you obviously defibrillate. Quite good with the basics of 200 joules biphasic or 360 monophasic. We obviously weren't doing AED mode because that's specific to Ambulance Victoria. I think one of the difficult parts was definitely trying to keep an eye on that 2-minute cycles, because obviously with CPR fatigue, meant to switch over every 2 minutes, and wasn't utilising the time on the monitor. In first year we had done using AED mode, a similar scenario which tells you when the 2-minute cycle is up. So I think verbalising that to your partner, as well, verbalising what you're doing and what your plans are, as well as keeping an eye on the 2 minutes was quite difficult at first. And obviously where to fit in, when do you go for the IV? Seal on the mannequins is quite challenging, because we're not sure whether it's the mannequins or the technique that's not working. But other than that, the ventilations, and with all the partners that I had, it was very clear that I wanted them to verbalise from 25, 26, 27, 28, 29, 30, and then I would count out verbal 1, 2, and then back into CPR. So I guess, making a sense out of the situation, it was initially, especially, I was going off basic guidelines, and this is what you need to do, without sort of playing the big picture in what was actually happening with this patient. I had a VF once, and I just said, all right, VF, that's shockable, let's do this, this, and this, without actually thinking, all right, VF, so that their heart's really not working, it's pumping, but it's not pumping the right way, all that sort of stuff. So I guess it was initially especially running off a bit too much of just, this is what the book says, rather than understanding the concept behind it, which obviously is very important in terms of deciding medications and further treatments. Certainly what I would have done is a bit better communication with my partner in terms of getting them to also help me keep an eye on the 2-minute cycles. Probably I would say the person who's doing ventilation should be keeping their eye on, unless they are off doing IV. Definitely would have called for mica a lot sooner. Sort of both main 2 times I did it earlier. Certainly forgot to do that until rather late, which obviously needs to be done really early. Printing off lead strips, forgot that a couple of times the first time I did it. And making sure you've got time to do that pulse rhythm check, the 2 minutes, and then get off a defibrillation if you need to. There's certainly a lot better communication that could have happened there, and if it arose again, would definitely call for mica earlier if necessary, and would definitely take that a little bit more time and not rush the ECG interpretation quite so much, because it's obviously very important. And a bit more preparation with my partner beforehand. Obviously, if you get the call out, you have a rough idea what you're setting into, and you can sort of plan accordingly, at least to some degree. Would definitely do that next time, whoever I was with, whether it's a new partner or a partner I've had before. So it's some better communication. Be more relaxed with the analysis of the rhythm. Call mica earlier. Feel a lot more confident with IVs and also where the materials are, which we've had a bit more practice at now. And just the overall management of the situation. And in the last one we had the 4-person, so the 2 crews show up, and just it got pretty frantic at one point trying to delegate jobs to each of the members. So it's something obviously that comes with practice, but it's just about being confident to run through the scenario in your head without taking time to stop and think about it, which I feel I'm a lot more comfortable now than I was before.